So today we're going to talk about narcissistic personality disorder. And in full disclosure, I've spent way too much time reading about this particular disorder for my liking in the last couple weeks to try to make sure that I covered all of the relevant aspects of it. I feel like this is one disorder that maybe I did not get as ample of an education about during grad school as I would have liked, but I've seen a number of presentations from grand rounds to even some podcast episodes dedicated to more of the nuance around this personality disorder. So I wanted to try to capture some of that, and there might be some gaps because we can only cover so much in a certain amount of time, and if there are gaps, we can always come back to stuff that you are all interested in again in the future. So the term narcissism was first described by the Roman poet Ovid in his work Metamorphoses, Book 3. The myth of Narcissus it centered around the character Narcissus, a character that had been cursed to fall in love with his own reflection. Narcissistic qualities are not implicitly pathological, as we all know, and these traits are part of normal human development. Bless you. Narcissism, the traits manifest around age 8, increase in adolescence, and then typically decrease during adulthood. It's when we don't see the decrease that we stumble into more of a pathology kind of a space. So narcissistic personality disorder is a pervasive pattern of grandiosity, whether in fantasy or behavior, a need for admiration, lack of empathy, beginning at early adulthood and present in a variety of contexts, as indicated by 5 or more of the various things on the screen here. So at least 5 in order to classify as a personality disorder, and this is according to the most recent iteration of the DSM, so the DSM-5-TR. So grandiosity in terms of a grandiose sense of self-importance, so exaggerating one's achievements or talents, expecting to be recognized as superior or better even without the equal achievements to prove this. And it can include an underestimation or a devaluing of the contributions of others in situations like teamwork. Preoccupation with fantasies of unlimited success, power, beauty, brilliance, or ideal love. These people will often compare themselves favorably to famous or privileged people. Belief in being special and unique, that they can only be understood by or should only be associated with other special or high status people or institutions. They may be surprised or even devastated when recognition isn't as forthcoming as they think it should be. And they really think that they can only associate with the best or the highest ranking, and then devaluing others in the process. So these would be the patients that want to see, the head attending that's an MD or DO, and are not going to necessarily want to talk to a nurse practitioner or physician assistant. They might even treat that physician, those other individuals poorly. They may demand excessive admiration. Their sense of self-esteem is pretty fragile. They often struggle with internal self-doubt and self-criticism, feelings of emptiness, and really look to others to fulfill these needs for them. A sense of entitlement, unreasonable expectations of especially favorable treatment or automatic compliance with their expectations. Belief that others should really understand how important their work is or how important they are. And they can become aggressive when these expectations aren't met. Interpersonally, these individuals can be exploitative, which results from both that sense of entitlement and a lack of empathy. So they're willing to use others to achieve their needs. A lack of empathy, so being unwilling or unable to recognize and identify with the feelings or needs of others. We'll talk a little bit more about this further into the presentation. Envious of others, or belief that others are envious of them, and they may begrudge the success of others around them. And arrogant, haughty, kind of snobbish behaviors or attitudes. So people that they'll display themselves as kind of patronizing, pretentious, even aggressively rude. And what's not in the formal diagnostic category, but is important, and we're going to talk a bit about, is vulnerability. While grandiosity is a major focus within the DSM formulation, there is this vulnerable piece that I think is maybe less recognized and less discussed. So the DSM does provide an alternative model for diagnosing personality disorders, and they're defined within or in terms of impairment in personality functioning and pathological personality traits. So using this model, typical features of narcissistic personality would include variable and vulnerable self-esteem with attempts at regulation through attention and approval seeking in either overt or covert fashion. There are 4 areas of personality functioning or character difficulties that are organized into 2 dimensions each. So self is organized into identity and self-direction, and interpersonal relations is organized to empathy and intimacy. And then 2 personality traits, which we'll talk about in the next slide. But identity, so this would be for narcissistic personality disorder, or NPD. These individuals would have an excessive reference to others for self-definition, self-esteem regulation, exaggerated self-appraisal, which might either be inflated or severely deflated, often vacillating between the extremes, and emotion regulation mirroring fluctuations in self-esteem. When it comes to self-direction, their goal setting is going to be based on gaining approval from others. They might have unreasonably high personal standards or unreasonably low personal standards based on a sense of entitlement. They're often unaware of their motivations. Empathy, so an impaired ability to recognize or identify the feelings and needs of others, excessively attuned to the reactions of others, especially when they're seen as relevant to the self in some way, and an over or underestimation of their own effect on other people. In terms of intimacy, their relationships are largely superficial. They exist mainly to serve in some type of self-esteem regulation, and there's little genuine interest in others' experiences, with really their own need for a personal gain to be predominant. The 2 pathological personality traits are also emphasized are grandiosity and attention seeking, both of which are representing 2 dimensions of antagonism. Other traits of antagonism that aren't necessarily part of the criteria, but may be seen and are worth noting as evidence of increasing pathology would include manipulativeness, deceitfulness, and callousness. Or in the case of more vulnerable presentations, you might see more affective negativity, so depressiveness, anxiousness. The dimensional approach has the strengths in that it provides a clinically meaningful description of the patient's individual personality patterns, their subjective motivation and experiences, and it attends to fluctuations and the range of presentations, looking at incorporating a sense of internal self-agency, self-control, and emphasizing those complex interactions among various capabilities, deficits, self-regulation, motivations, and self-enhancement that really kind of color the expressions of self. So I don't know who all has seen the show, but I was trying to think of some fictional characters that maybe would easily represent narcissism, and I think that the show Succession does a really nice job with this. I grabbed both of these photos from IMDb, the page about the show. I don't know if they're in the public space or not, but I'm hoping so. I just really wanted to highlight the characters. And when I think of kind of the most classical, grandiose presentation of narcissism, I think about the father in the show, where I think that the show writers and the actor did a really good job of highlighting the complexity and fluid ways that a vulnerable narcissism presentation can show up. People with narcissistic personality disorder can have a wide array of functioning, from relatively okay to highly malignant and pathological. They might present with overt or covert expressions of symptoms. Professional capability combined with self-control, stoicism, and interpersonal distancing, really with a minimal sense of self-disclosure, can support a sustained life engagement with high achievements. But fluctuations in self-esteem can create problems. Some individuals are going to have very low functioning, which might reflect an unwillingness to risk any type of failure or defeat. You may see high perfectionism, which often reveals a significant fear of failure and overwhelming emotions. Low self-esteem, envy, vulnerability, humiliation, shame are all things that can predispose these individuals to also experiencing comorbid depression. And rather than a flexible, reality-based sense of self-experience that characterizes your typical, quote-unquote, normal identity formation, the sense of self in somebody with NPD is more brittle and kind of removed from reality. What characterizes this disorder is a spectrum of more or less fragile sense of self that's grounded in maintaining a view of oneself as exceptional. It doesn't apply just to grandiose narcissists, but also to the vulnerable subtype, where the grandiosity is kind of cloaked under feelings of inferiority and deficiency. Narcissistic personality disorder is associated a lot with self-esteem regulation and emotion regulation. Clinically, these parents may present with a wide variety of symptoms, but mostly with most of them, you're going to see a pervasive difficulty maintaining self-esteem. They tend to have strong internal reactions to disappointments, rejections, challenges to self-esteem, which they often may try to dissociate from and deny. And both the overt and covert dimensions are really independent of whether you see the grandiose or vulnerable presentations. These individuals with low explicit self-esteem sometimes might have low explicit self-esteem, where in patients with a higher severity, you might see both low explicit and a high implicit self-esteem, really showing a lack of integration between how they're perceiving themselves. Feelings of envy or shame might impact their self-esteem, and self-esteem regulation and emotion regulation mutually affect each other in several different ways. Grandiose narcissism might become selectively related to angry reactions in response to threats of failure, and maybe not rejection, whereas people with vulnerable narcissism react with anger to any sense of rejection, but not so much failure. Researchers publishing in this area have noted that avoidant dismissive cognitive processing, increased risk-taking, difficulty learning from mistakes, and a self-serving attributional bias, irrespective of one's own performance, and the use of language for self-regulation are very common. The language used for self-regulation, not so much communication. Early psychological trauma is not uncommon amongst these individuals. It's noted that often there is embedded a sense of deep shame from these early psychological traumas that might not be verbalized or even really accessible for them to put words to. And sometimes the covert presentations occur because of that history of being humiliated, shamed, or criticized in some manner. These individuals, when it comes to an extreme level of pathology, have a tendency more towards more planned out and lethal suicide methods, as opposed to more impulsive attempts. And an additional dimension of pathological narcissism is that it's relatively invariable over time. So people are going to show a mixture of overt and covert features across any different domain, depending on their particular individual presentation. So Day et al. Conducted a study looking at clinicians' formulations of narcissistic personality disorder using two clinical vignettes, one that was more grandiose and a different one that was more vulnerable. And this table shows how the clinicians viewed personality functioning, traits, and clinical themes across the two. So personality functioning, so on the more grandiose side, and some identity rigidity, idealized self-worth, inflated self-appraisal versus identity absence, devalued self-worth, and a deflated sense of self-appraisal and vulnerability. Interestingly, Anacostia, sorry if I'm saying that word incorrectly, too many consonants too close together for my mouth to get out today, was noted across both grandiosity and vulnerability. Anacostia being a kind of compulsive, perfectionistic, rigid sense of or desire for control. And it's a personality trait that might not always show up, but can show up whether the presentation is more grandiose or vulnerable. Under clinical themes, on the grandiose side, there was more of a sense of entitlement and self-centeredness, belief in superiority, high conflict with others and devaluation of others, and interpersonal hypersensitivity was seen, where on the vulnerability side, the clinical themes showed up a lot as depression, anxiety, shame, victimhood, superficial idealization, some distrust, sometimes even paranoia and resentment. That same Day study, where they had the clinicians look at the two clinical vignettes, this is a qualitative map of the clinicians' responses reflecting on the grandiose concept on the left and vulnerable on the right. The bold words reflect kind of themes, where the italicized words reflect individual concepts. What's interesting in their work is, and I think not too surprisingly, the grandiose presentations seem to elicit a more negative feeling from clinicians when they were talking about them, whereas the vulnerable presentations elicited more pity. The literature does note that we are much more likely to encounter these individuals seeking mental health treatment of their own volition when they fall into that more vulnerable bucket, where we're less likely to see the grandiose presentations, or when we do, they might not be in therapy because they want it, but because they've been pushed into it by a family member, coworker, some type of external rationale for them to being there. So as I noted before, self-esteem for people with narcissistic personality disorder is fragile. Social dominance and leadership can be really important base for their self-esteem, and a motivational source that can provide a sense of attention and a sense of competence and control. Their self-esteem and sense of self-worth can be affected by various factors and circumstances, external markers in social, professional, physical, material, financial contexts, interpersonal affiliations, interpersonal attention, a sense of internal control, with consistent ability to predict and understand context, emotions, and interactions are all essential for self-esteem and sense of self-agency. People with a narcissistic personality disorder, their sense of self-esteem can also be assessed interpersonally, looking at the emotional or relational performance and social maneuvering. Narcissistic patients, a sense of agency can be essentially a catalyst for interpersonal competence, also for self-enhancing through manipulation and interpersonal control. Some might have a more consistent sense of self when it comes to work, but can recognize that in other situations, maybe those that are more social or unstructured, they might feel vigilant, vulnerable, and insecure. Some might be highly achieving, ambitious, and successful with really well-controlled and smooth social skills, while also at the same time being relatively unaware of their areas of fragility, like in the more intimate interpersonal relationships. Any impact of life events and changes, especially those that are unexpected, can severely rupture an individual's sense of self and sense of self-esteem and their regulatory pattern, including both enhancing and avoiding protective strategies, which can lead them to a loss of functioning and unfolding of more severe traits and pathology, even potentially suicidal ideation and behaviors. These individuals often struggle with emotion regulation as well. So alexithymia, I'm really killing myself with the tongue-tying words today. It refers to the inability to feel and identify one's own feelings, either due to unawareness or incapacity to distinguish between physical and affective states, or because of the lack of words for emotions, just not having language for it. This inability or deficit can contribute to significant emotion dysregulation for people with narcissistic personality disorder, as well as towards difficulties in identifying, understanding, and processing others' feelings, so that empathy. Patients with narcissistic personality disorder can have problems with different aspects and a range of the range of emotional regulation skills. The ability to feel a feeling, tolerate the nature of that feeling, identify and kind of give language to it, and translating emotional experiences into something that can be verbalized and communicated to others. They may have trouble integrating their own feeling and attention into those interpersonal interactions that are congruent with kind of more moral, ethical values or social conventions and norms. They tend to have a compromised, but might not fully lack empathetic capability, and this can result in a range of interpersonal responses to other needs and reactions, from total ignorance and avoidance to dismissiveness or even aggression. They might be extraordinarily attentive and give care to certain contexts where engagement is important, but it's really associated with the self-enhancement and looking for their own possible benefits. Sometimes these individuals can appear unaffected by losses, things that would normally evoke a sense of grief or sadness. Really, they're trying to stay kind of protective of self in those situations. Their extreme hypervigilance or reactivity to certain threats are really notable. They can lead to drastic impulsivity, violence, and once again, potentially suicide. Motivation, willfulness, and deliberate enhancing or of defensive manipulative communication can also be present in their interactions. In some patients with narcissistic personality disorder, they might present in a social, friendly manner with exceptional verbal skills. They might even appear to have the ability to integrate appropriate intentional vocal tone and phrasing of emotions, but this is really disconnected from their genuine emotional experience. And this compromised feeling capacity to feel, identify, and tolerate and process feelings can really lead to an intense preoccupation with trying to maintain a sense of control. So empathy, the ability to understand another person's feelings or situation. Empathy can be channeled into prosocial and antisocial behaviors. Individuals with narcissistic personality disorder might demonstrate a combination of a difficulty recognizing emotional facial expressions, along with a hypervigilance towards certain negative and neutral emotions, and sometimes a propensity to react with anger. They may have a sense of elevated fear and avoidance, and reading other emotions might be done really to reach personal purposes. But as soon as emotions are interpreted as feeling threatening, they're going to avoid them. Engagement in prosocial behaviors that appear to come from a place of empathy tend to be strategic, whether that's to gain visibility, to be seen as talented, to be seen as compassionate, while the idea is to be seen as compassionate rather than actually being compassionate. Subjects with high levels of narcissism tend to show lower degrees of perspective taking when administered the interpersonal reactivity index, especially around questions about the willingness to focus on empathic distress. They're able to recognize the emotions of others, but sometimes lack the motivation to relate to them. Rivalry is something that comes up and predicts a lack of acceptable emotional response or recognition to someone else's feelings, but also can show some contradictory effects and show some affective dissonance. Intolerance towards emotions can play a role also, since the subject might detect the feelings of others, but that the sense of them might be overwhelming. They might attach that to a sense of deprivation, shame, or loss of internal control, and which could result in them responding aggressively or with total withdrawal. The DSM-5 notes that up to 75% of those diagnosed with narcissistic personality disorder are males, which suggests that the representation of narcissism might only marginally apply to females. But the criticisms of the DSM fall around the fact that there seems to be an overemphasis on grandiose presentations and an underemphasis on vulnerable presentations, which predispose our diagnoses towards a more stereotypically male presentation, where the alternative model and more psychodynamic conceptualizations of narcissistic personality do a better job at capturing both grandiose and vulnerable features, with vulnerable narcissism showing more elements of shyness, hypersensitivity, rumination, shame, and low self-esteem. The grandiose features of narcissism have been linked closely to male socialization characteristics, particularly in kind of Western societies. Displays of physical aggression, authority, excessive need for power and status, where the kind of stereotypically female socialization are less likely to exhibit those kind of overt stereotypical narcissism features, where their expression might resemble more feminine qualities in that vulnerable spectrum, such as shame, inhibition. This is particularly concerning in light of potential misdiagnosis of vulnerable narcissism, given its potential overlap with borderline personality disorder and avoidant and dependent personality disorders. Clinicians do, and when this is researched, they do diagnose narcissistic and antisocial far more in men, where they're diagnosing borderline, histrionic, and dependent personality disorders much more in women. And this kind of just highlights this a little bit further. There was a 2023 study that did demonstrate, the borderline dependent and avoidant personality disorders most frequently being endorsed when the clinicians were presented with a female patient case that was exhibiting vulnerable narcissistic symptoms. So in this situation, the vignettes were either vulnerable narcissism, grandiose narcissism, or panic disorder to completely throw them out of the water and be like, this isn't a personality disorder at all. And then the genders were switched. So you could see that when grandiose was the actual diagnosis underneath all of it, when it came, and grandiose for the most part was diagnosed as narcissistic personality disorder. But when vulnerable was the kind of actual underlying presentation, you saw a much wider variety of where that was getting diagnosed. So there's 4 variations in presentations that I found in a handful of studies. I'm going to read through 2 of them just to highlight how some of these are different. Mr. A is a 42-year-old married man presenting with private practice psychotherapist complaining of problems with his wife. He's a successful entrepreneur, competitive, enjoys social gatherings. He tends to be the center of attention at social gatherings, as well as challenges at work. He believes he has a superior ability to solve problems. He's coming to treatment because he wants to know whether or not he should stay in his marriage. He said that he's lost all sexual interest in his wife during their early years, and throughout his marriage, he's maintained a series of lovers who he's housed, supported, then cut off and replaced. He feels that this arrangement has had no impact on his relationship with his wife, but wonders if he would do better with someone else. So this would be kind of your very stereotypical high-functioning narcissist. Mr. B started therapy, describing himself in a confident, haughty way. He self-identified as arrogant, very competitive, dreaming of making the 30 under 30 list. 2 sessions later, he describes a paralyzing sense of insecurity, shame, and rejection to sensitivity in his romantic relationships, worried about losing his partner because of his almost invisible hair loss, possibility that he might not make enough money, and worried that he'll run out of jokes to make her laugh. So this presentation shows more of that co-occurrence of grandiose and vulnerable, which expresses itself sometimes in different ways in different sessions. Miss C's started treatment in the context of pervasive insecurity about social interactions. She describes difficulty initiating conversations because of fear of rejection and feelings of shame, combined with a tendency to be easily offended and an expectation to be automatically accepted by others. After a few months of treatment, she describes a deep-seated tendency to judge herself and others and think of others as incompetent and stupid. She wanted to feel better than others and frequently fantasized about becoming a world-famous artist, thus proving herself to be better than others. So this kind of shows that patients can display the intermix of grandiose and vulnerable all at the same time, so concurrently, and they present with the coexistence of seemingly contradictory traits and modes of operating all within the same time. And Miss D, a 44-year-old single woman, referred to a group specializing in severe personality disorders where she complains of refractory depression for which she was on medical disability. She'd been treated for 10 years under every modality the hospital could offer. She portrayed her previous therapist scathingly and derogatorily, seeming to find gratification in their failed attempts to help her. Her group therapist diagnosed her with narcissistic personality disorder based on the gap between her self-image as an extremely gifted but unrecognized author and the reality that she had written almost nothing. Antisocial features consisted of chronic lying, prostitution, working the system to obtain disability payments, and there was no neurovegetative symptoms of depression that were notable. So when her new therapist raised the possibility of working towards employment, Miss D coolly declared that she would just kill herself first, or him, if he interfered. So a little bit about focus on treatment, and we could certainly always cover this on another day, but when starting treatment with patients with narcissistic personality disorder, whether you're seeing them in a primary care practice, in a mental health setting, regardless of where it is, you really want to start to engage them with alliance building. Independent of what the treatment modality is outside of that, really trying to build some type of alliance and connection with them and start to explore and identify the roots and underpinnings of their narcissistic self-regulation in general, and then specific situational self-esteem and emotion fluctuations. It's important to gradually differentiate those patterns of self-esteem fluctuations from those that are primarily triggered by emotion dysregulation. Exploring an exploratory approach with them using non-judgmental curiosity and interest might be helpful to minimize any kind of negative emotional reactions. Even when the alliance has been established and a collaborative therapeutic process, is there with trust and respect and understanding, emerging conflicts or life events can suddenly re-evoke the patient's resistance with avoidance, reactivity, or dismissiveness. So it's important to keep in mind that these patients are struggling with reactivated internal trauma sometimes, and that the subjective meaning experience of that earlier event are impacting their current self-esteem. A shift from preoccupation towards control, enhancement, avoidance, or dismissal towards more interest and attention to others can be significant in helping them to change their personality functioning. Such change can be possible when patients have gained the understanding and sense of control and recognize their ability to organize it, tolerate, and find meaning in their own internal experiences. We want to make sure that we're addressing any comorbid conditions. Comorbid conditions are likely to have a persistent functional impact. Younger individuals tend to show a little bit more improvement if you can start things with them early. And treatments for these patients generally are fairly difficult. Interpersonally, these patients are capable of fluid adaptability, guided a lot by impression management. This adaptability can create a chameleon-like clinical presentation, which could be accompanied by theatrical, performative, and really disingenuous atmosphere. So establishing what is the interpersonal narrative that they're invested in might be helpful for you in guiding our own internal reactions to them and helping them in guiding themselves, or helping them guide towards more self-assessment, self-reflection. And so can we build some of their empathy or rebuild some empathy if the idea is that they have some cognitive aspects of empathy and they're able to kind of understand from an intellectual level what's going on with another person? Can we help to build the affective empathy through that? DBT techniques can be particularly helpful. It's based on the idea that emotions might be frightful at times to them and unbearable. So a skills-based approach at recognizing how they can identify and determine their own needs and values could be very beneficial in pushing them towards a place of more functional interpersonal interactions. And helping them practice some perspective taking could certainly do some of that. Regardless of the therapeutic setting, addressing any kind of interpretations as questions or hypotheses is likely to maybe help them introspect a little bit better, but also reduce the likelihood of their negative responses. And really just addressing empathy through education, training, it could be efficient ways to get to the heart of their inadequacy. Here's a list of references that I utilized, the first one being the most recent DSM, and then a variety of articles. And that is what I've got.